One of the challenges what we see in pediatric intensive care unit is the convulsing child. How to stop this convulsion? Because it is very important for us to recognize it early and terminate it early. Because the longer it's going to take, it's difficult to control. Definitely it's going to have damage to the brain and also on the respiratory system. Also with the high dose of anticonvulsant which we'll be using, it's going to have a problem. So coming to the status epilepticus, it presents in a multitude of forms. It depends upon the etiology and the patient age. It could be myoclonus, it could be tonic, it could be subtle, it could be tonic-clonic, absence or partial seizures. And as per se what we see in pediatric intensive care, more of almost 80% of the case of status which we see is usually generalized tonic-clonic type of convulsion. Conventional definition of status, a single seizures which is lasting for more than 30 minutes or series of seizures with more than 30 minutes without full recovery of consciousness. But operational definition, because if you see a non-febrile epilepsy usually terminates within the 4 minutes. So operational definition should be a continuous seizures which is lasting at least 5 minutes or 2 or more discrete seizures between which there is an incomplete recovery of consciousness. If appropriate therapy is delayed, status can cause permanent neurological sequelae or death. Thus, any child who presents with actively convulsing should be assumed to have status epilepticus and treated accordingly. Longer the status persists, lower is the likelihood of spontaneous cessation of this convulsion. It is going to be harder and harder to control as the time elapses. Higher is the risk of morbidity and mortality in longer the convulsion. So the treatment needs to be instituted before 5 minutes of continuing convulsion. So what are the causes? Causes is per se in pediatrics, what we see is the fever-induced convulsions constitute about 36%. Then medication change, child was on anticonvulsants and the medication has been changed or reduced the dose. These are those things. And third is metabolic problems of hypocalcemia, hypoglycemia, hyponatremia or congenital structural anomalies, anoxic brain damage, other like vascular infection or tumor constitute about 15% of convulsions. There should be one point of importance is sometimes the drugs what we use in intensive care itself will produce the convulsion. One this thing is should be beta-lactam antibiotic. Most of us usually use cephalosporin. So this itself can induce a persistent convulsion. What is the mortality? Mortality in various studies has shown anywhere between 3 to 15% in children who are having a persistent convulsion. So what happens in these children with a prolonged convulsion? So usually as the convulsion starts, there is a temporary phase where there is systemic changes takes place. There will be catecholamine release, the body tries to adapt. Then as the duration of the convulsion increases, there will be life-threatening systemic changes which ultimately produce death. So what are the challenges what we see in intensive care unit in a child who is on status? One is the hypoxia and hypocarbia because of the decreased ventilation, because of chest rigidity and muscle spasm. There is increased hypermetabolism with increased oxygen consumption and increased carbon dioxide production. Poor handling of the secretion. Actively convulsing child could aspirate or neurogenic pulmonary edema could be some of the problems. Hypoxia or anoxia markedly increase. Almost in a child who is having hypoxia, the risk of mortality in status is almost 3 times a child without anoxia. Seizures without an hypoxia are much less dangerous than seizures with hypoxia. A neurogenic pulmonary edema, one of the rare complications, it likely to occur as a consequence of marked increase in the pulmonary vascular pressure during the status. What about the acidosis? They could have respiratory acidosis, they could have lactic acidosis because of impaired tissue oxygenation or increased energy expenditure. What happened to the hemodynamics? Initially, as the child convulses, There will be initially sympathetic overdrive. There is massive catecholamine release with autonomic discharges. Initially, child would have hypertension, tachycardia, the CVP will be raised. But as the time elapses, as it overshoots 30 minutes, then the exhaustive phase takes over, where you can see there is a hypotension and hypoperfusion. Here you can see the cerebral blood flow with the cerebral oxygen requirement. As the seizure duration prolongs, initially there will be increase in oxygen requirement, and there is increased cerebral blood flow. So increased cerebral blood flow trying to meet the cerebral metabolic requirement here, and as the convulsion duration increases, it slowly starts coming down. Blood pressure also takes the similar route. It initially increases, and as the neuronal exhaustive phase comes in, the cerebral blood flow drops as hypotension sets in and autoregulation gets exhausted, and finally the neuronal damage ensues. What about the glucose? So initially there will be hyperdynamic phase, there will be increased catecholamine release, so you can have hyperglycemia with that, but as the duration of the seizure increases more than 30 minutes, you can, in the exhaustive phase, the hypoglycemia develop, and hypoglycemia actually occurs much earlier in children who have status with hypoxia. What about the hyperpyrexia? It is possibly due to mismatch between the metabolic requirement and substrate delivery. It is very important with the child who is convulsing to reduce the temperature. You can treat the hyperpyrexia aggressively by antipyretics or external cooling, continued external cooling. And this is the time when you can also consider the intubation, so that the child is relaxed, there is no active convulsion which is taking place in this child. Other alteration in child who is actively convulsing, there will be increase in blood leukocyte. What happens is, from the spleen and from the bone marrow, there is immediate discharge of this WBC. So you can see more than 50% of the children have leukocytosis. There could be about 15% of CSF leukocytosis in 15% of the children. There will be hyperkalemia, increased creatinine kinase, and myoglobinuria in children who continue to convulse for a longer time. Management, ABC is very important. Make sure you avoid hypoxia. If you're not able to get initially consider bag and ventilation so that the child won't be hypoxic, and if the child is actively convulsing, there is hypoventilation, consider intubation. Try IV as early as possible. If you're not getting IV, don't wait for a longer time. Get an intraosseous line in and treat the hypotension, but not the hypertension. Because hypertension is initially the body is trying to get the CBF up so that it will perfuse the brain. What about the arterial gases? All the children in status do have some amount of acidosis. It often resolves rapidly with the termination of status or the fluid resuscitation. These children need continuous pulse oximeter monitoring, ECG, because of hypokalemia, whether this child are going to cardiac arrhythmias. Make sure the BP and urine output is monitored well. Rule out any infection. Try to find the etiology. Do a blood culture and urine culture. And continuous ECG monitoring is indicated in children who have got long-term neuromuscular paralytic agent. Once you give the paralytic agent, consider the child is still convulsing. And in children who have got a prolonged postictal phase, that you have given the medication, but the child is not responding, still in the postictal phase for a long time, consider the EEG monitoring. And any child who has got a refractory status epilepticus. When to intubate? It may be difficult to intubate as actively seizing child. All of you have got experience actively seizing. It's next to impossible to do it. You have to use a stop or slow the seizures first. By giving the anticonvulsant, give oxygen, consider bag and vent ventilation till you are able to intubate the child. If you are using paralytic agent, intubate and assume that the status continues till you can do a EEG to rule out that the seizures have subsided. Lab investigation, you have to do the electrolytes. The cause could be hyponatremia, calcium, magnesium, phosphate, glucose, total blood counts to rule out any infection, liver function test, ammonia, If the child is already on anticonvulsant drugs, it is very important for us to take the blood for the anticonvulsant level just to see that whether the child has been taking anticonvulsant drug or not. If you are suspecting any poisoning, do the toxicology screen. And in infants, smaller children who comes with a first time convulsion, it's very important for us to rule out any inborn errors of metabolism. So inborn errors of metabolic screen also should be done. Creatinine kinase would be high in most of these children who are actively convulsing for a longer time. Lumbar puncture. When the child is actively convulsing, it is always better to defer a LP in an unstable patient, but never delay the antibiotic or antiviral treatment if indicated. CT scan is indicated for focal seizures or deficit in a history of trauma on building in acute setting. Treatment. Most of the children would be hypoglycemic when they present to you, so make sure the glucose level is maintained. So give glucose at the rate of 2 to 4 ml per kg, 25% dextrose in the older children, and infant 5 ml per kg of 10% dextrose unless they are normal or hyperglycemic. It is shown that hyperglycemia has got no negative effect in status epilepticus. And correct, if there is hyponatremia, correct the hyponatremia, hypocalcemia, correct the hypocalcemia. The longer you wait with anticonvulsant, the more anticonvulsant you will need to stop the status. Most common mistake, what we do is to give inappropriate or low dose of anticonvulsant for the fear of producing respiratory depression. So when the child comes in a premonitory stage, within the 5 minutes, you support the airway, breathing and circulation. The drug of choice is usually benzodiazepines. Obtain a IV, use the first line therapy, benzodiazepine. Usually in our setting we use lorazepam because it has got a lesser respiratory depressive action. Early stage, between 5 to 10 minutes, check the glucose, correct the abnormalities. If needed, hypoventilation, intubate if there is hypoxia. Repeat, if still the child is convulsing, repeat the first line drug IV, but also administer the second line drug as early as possible. 10 to 15 minutes, begin appropriate diagnostic test and empirical treatment if there is any infection. Optimize the second dose, the correct dose. By the time 15 to 30 minutes, if the facilities are there available, start with the EEG monitoring, airway ventilator and vasosupporter as required. In more than 30 minutes, you consider it to be refractory seizures. You may need the invasive arterial monitoring. You may need a CVP monitoring and continuous EEG monitoring, and consider whether this child should go in for pharmacological coma. So anticonvulsant, it's very important, like as soon as we give the rapidly acting drug, it is also very important as early as possible, if it is not responding, to use a second line of long-acting anticonvulsants. The rapid-acting anticonvulsants, which all of us are familiar with, lorazepam 0.1 milligram, it is less rapidly acting, short-acting, and it's given at a dose of 0.1 milligram IV for 1 to 2 minutes. Second is diazepam, which is very popular, or midazolam. Midazolam, one thing is good is that if you're not able to get an IV, it is almost 90% of the drug is bioavailable if you give IM. You can also use nasal, or you can use as a sub-buccal through the buccal route. If the status persists, you can repeat this anticonvulsant every 5 to 10 minutes till it gets controlled. The long-acting anticonvulsant, what we use is phenytoin, give about 20 milligram IV over 20 minutes, or fosphenytoin, 20 milligram per kg over 5 to 7 minutes. If you're using phenytoin, the problem is chance of extravasation. It can cause necrosis, or it can cause arrhythmias. Phenobarbital is the other drug. This is the first line of treatment in neonatal status, but here generalized status as a second or third line drug, we can use phenobarbital. So initial choice of long-acting anticonvulsant, I've already told how to select whether the phenytoin or fosphenytoin. If the status persists beyond this time, This is the time when you can consider to start with midazolam infusion. Give about 1 to 10 microgram per kg per minute after a bolus of 0.1 milligram per kg. Or you can think of starting pentobarbital or thiopental infusion at this rate. It is very important for us to know whether the convulsions have really stopped or the child is having what is known as non-convulsive status. What happens after some time? There will be electromechanical dissociation. There will be a cessation of the clinical manifestation of convulsion. Only the EEG would show the seizures. So how do you tell that patient's seizure have terminated? The neurological signs after termination is there will be pupillary changes, abnormal tone will decrease, then posturing will come down, clonus will be absent, maybe abnormal asymmetrical tone will be there. So about 20% of children with status have non-convulsive seizure after tonic seizures. About 20% of them, even after giving that, would have about the non-convulsive seizures. If the child does not begin to respond to painful stimuli within 20 to 30 minutes after the tonic-clonic status, suspect non-convulsive seizures and urgent EEG is required in this children. If the child is still convulsing, then we call it as refractory status, which is even after, despite of using drugs, 30 minutes onwards the child is still convulsing, we call it as refractory status. There is no accepted definition. Any status epilepticus of any classification that failed to remit despite of treatment with adequate dose of 2 anticonvulsants is termed as refractory seizures. About 30 to 50% patients fail initial benzodiazepine or phenytoin treatment can have refractory status. So expert consensus, all the current guidelines advise that by this stage the patient should be considered for pharmacological coma, which is the most important thing is to urgently suppress the seizures, because time is brain, longer you take it's going to produce the brain damage. Manage the systemic adverse effects of the prolonged convulsion, find the possible etiology. Status becomes more refractory with time. It is going to be more and more difficult as the seizures persist. And refractory status has got a mortality rate of very high, about 20%. So what about the anesthetic agent? What is the choice of agent and what is the depth of anesthesia what we have to use? Here they have in this trial of 193 patients, they have compared 3, that is midazolam, they have pentobarbital and propofol were compared. Here you can see acute failure. The midazolam and your propofol had more than pentobarbital, where breakthrough seizures and withdrawal seizures were more with the midazolam, whereas hypotension was noticed maximum with the pentobarbital, whereas continuous intravenous anticoagulation therapy was needed more with propofol and midazolam when compared with the pentobarbital. Surprisingly, all 3 had the similar mortality rates in this series. Propofol in the treatment of refractory status, 10 pediatric patients with the RSE terminated, the propofol terminated seizures activity in all initially. Quality of burst suppression was unsatisfactory in this children. Incremental dose of propofol was needed. They had kept on increasing the dose till the burst suppression was achieved. It needs a continuous EEG monitoring to use propofol. Stepwise weaning, risk of emergent seizure activity is present. Reduction in 5, it's very important to slowly reduce the infusion rate of propofol over the time. And weaning time from the ventilator was 50% quicker than when they used with the pentobarbital. High dose pentobarbital in a treatment of refractory seizures in intensive care unit from neurology. It is almost similar to propofol. Effectively terminated the seizures, easier to attend and keep burst suppression when you compare with the propofol. Doses needed higher than the generally recommended. Mostly whatever dose was much higher is needed to all of them to terminate. Recovery from anesthesia is prolonged. That is the problem with this agent, where you need prolonged ventilation. You may need a prolonged vasoactive support, so that the chance of ventilatory associated pneumonia is much higher when you compare with the other agent. But theoretically, advantage of pentobarbital being neuroprotective, as it reduces the cerebral oxygen demand and oxygen consumption is there, so it is a preferred drug. Refractory, this is about the aggressiveness of treatment on the prognosis. What it says is outcome was independent of the specific coma-inducing agent used and extent of ECG burst suppression, suggesting that underlying cause of the disease presents the main determinant in on the mortality rate. What if nothing works? There are other alternate anti-epileptic drugs. Yesterday Professor Singhi told they use sodium valproate as a third line drug. IV, you start with 20 milligram per kg initial bolus, which you can increase up to 40 milligram per kg. Then you can increase with a 3 milligram per kg per hour dose. Other drugs with the levetiracetam or topiramate has been used. Topiramate has been used more with the adult. Very few pediatric studies are there. You start with 25 milligram ng. You can increase that. But sometimes the child would have what is called as an anoxic metabolic brain, in the anoxic metabolic brain damage, post-anoxic myoclonic seizure type of thing. There is no need to treat that, this post-anoxic myoclonus. It would subside by itself. And longer, if it doesn't work with this, maybe we need a longer and deeper anesthesia to terminate the seizures. And there are some experimental method like surgical hemispherectomy, lobectomy can be done, or vagal nerve stimulation can be tried in these children where nothing works for them. Coming to the conclusion, in refractory status epilepticus, evidence for the treatment is poor. It's based on the retrospective studies. Initiate anesthesia with undue delay in refractory status epilepticus. Continuous monitoring until electrographic seizures are abolished. How long is unclear, but it depends upon the etiology. Barbiturate has some advantage over other agents, but at the expense of respiratory complication and prolonged PICU stay. Prognosis ultimately depends upon the etiology. Difficult status, serious medical condition with a high mortality rate, relative dearth of evidence on how to treat the condition. Pick your drugs, know them well and use enough. And any child who presents actively convulsing child should be assumed to have status epilepticus. Always use a rapid acting drug along with a long acting drug as early as possible. Prognosis depends upon the etiology, delay in initiation of appropriate treatment and unusual comorbid condition. Thank you.